Good morning, everyone. Welcome back. We have another exciting day, and I have the pleasure of moderating this session. Our session this morning is translating AI into clinical practice. And so hopefully we'll get some pragmatic, real boots on the ground information. So our first speaker is Fabio Llano de Moraes from the Department of Oncology, School of Medicine at Queen's University. So Fabio is an associate professor, radio-oncologist, and director for innovation and global oncology at the Department of Oncology, Division of Radiology at Queen's University and Kingston Health Sciences Center in Kingston, Ontario, Canada. He's a PI at the Queen's Cancer Research in Kingston, Ontario. So welcome.
Can you guys hear me well? Yeah? Okay, perfect. So good morning, everyone. So I'm happy with the invitation. It's my pleasure to be here. And it's my honor to be presenting on behalf of Queen's University. So today I'll be talking about bringing innovation to oncology. I'll try to be more practical, like pragmatic, how we can make AI available to all, like across the globe as well. So these are my disclosures. So our learning objectives here will be to summarize some of the health care pressing challenges, to review how we can apply AI to improve outcomes and decrease inefficiency in oncology, and also to discuss how AI and people can bring solutions to oncology. So the problems that we have nowadays is that medicine needs to be more precise and accurate. We all know that. We know that patient journey and engagement must be improved, and healthcare professionals, they need help. So for me, that will be the three pillars of this talk. So we need to understand how to help people and how to engage with patients to make medicine better. So when we talk about precision and accuracy, we all assume that all well-intentioned physicians or healthcare professionals will provide high quality, safe, and cost-effective care through hard work, use of the best evidence, and use of technology. However, we are lacking accuracy and precision, and that leads to treatments that are of low value for our patients. So what we want to move from low accuracy and low precision to high accuracy and high precision. So meaning that we are gonna be able to repeat the same results, and we are gonna be able to repeat the results that we want. So for patient journey, we need to improve the patient journey. We know that the patient journey can be extremely painful. We know that patients need to be part of the decision-making process. We need to expand access to medical knowledge, including methods, data, and risk literacy. And we need to support patient-centered care and value-based medicine. And for healthcare professionals, we know, especially during the pandemic, that healthcare professionals are stressed, overworked, and they spend the biggest part of their time dealing with bureaucracy and tests that are not related to care patients. And this is harming medicine and harming their actors, the human being. And cancer is getting only more complex, especially because it's growing in numbers. So if you look on this slide, in 2017, there were about 13 million people living with cancer worldwide with an impact of about $300 billion. And by 2030, we'll have almost double that, 22 million people and almost $500 billion. And this is growing largely due to growing in population aging and also lifestyle changes. But these numbers, they vary dramatically across countries and age. And we also need to realize that access to care is unequal, meaning that in 2030, 80% of the cancer burden will be in low and middle income country, but they only have access to 5% of the resources to treat cancer. So some solutions are patient-centered care, good use of data, and innovation. And that's what I'm gonna discuss today. So patient-centered care is that patient will be the center of all the healthcare needs and will be desiring to achieve outcomes that will provide a best care for our patients and also will improve their outcomes and quality of life. When I talk about data, we know that there is a lot of data, and we heard yesterday that we are receiving a lot of data, we are collecting a lot of data. There is a tsunami of data that we cannot stop, and we are leaving it, but we can prepare for it. And how do I like to say that we can prepare for it? And that's why what we are doing in my center. So we need to create and cultivate data sources. We need to harvest information. We need feed knowledge that makes impact, so from process to clinic, and then create a cycle. So then we need to recycle all this information and all this process so everybody can engage on the process. So in the end of the day, we want to go from rocks to a crawl. And innovation, innovation is new, better, or more effective ways of dealing with problems. And computer and AI is here to help us. We know that in the last 15 years, we have experienced a crazy amount of increase on processing capacity. We know that medical data from hospital is a big and important source of big data. For instance, a single hospitalization generates about 150,000 pieces of data. 10 years of hospital data equals about like 200 years of Dr. Wisdom, or about like 100 million outcomes data. But this is only useful if we have access to that and if we can understand that. However, our brain is not capable of doing or dealing with this amount of information, because our brain only can consider 5 facts per decision. So medicine and oncology is getting more complex. So every time that we are taking a decision now regarding our patients, we need to agree that one factor is more important than others. And the power of the computer will help us to bring like thousands, hundreds of informations all together to give us a framework to help on our decisions. So in 2022, we know that computers are an integral part of our work. AI is on the rise, but it's still far from clinical practice. We are generating a lot amount of data in oncology, but we still have a lot of pressure for regulatory frameworks, diversity, equity, and much more. So what we need to do now is to conquer and build a culture of innovation and implement AI to practice. So these are some applications of AI in oncology. So translational oncology, cancer imaging, including radiology, pathology, and others, clinical outcomes, clinical decision-making, and healthcare process. So we need to also teach our clinicians and people involved in the field. And we have a big discussion about this yesterday, about like good practice on AI and machine learning. So we need to have something that is relevant to the current practice. It needs to be consistent, it needs to be relevant, generalizable, and it needs to align with the intent research question. So first thing, asking what question you want to answer with this data. And there's a need to be like appropriate separation between training, tuning, and test data sets. So only that way we'll have an appropriate level of transparency of the output, and then we'll be able to impact on our clinical level. Because in the end of the day, our goal is to create value. And value, it's very important to be discussed, because value has different perspectives, correct? So you can have a perspective of the patient, of the healthcare, of the researcher, of the payers. So that's always important to keep in mind. Sometimes what is a high value for us might not be high value for the patient or for the health system. And I always like to remember this paper from my colleagues from Queens, from Dr. Gawali and Dr. Booth, that said about like the ground shot. Although that has been important progress in elements of cancer care, the cancer field is losing sight of what matters to the patient. So we always need to remind ourselves what matters to our patients. And when we talk about that, and we talk like losing sight of what matters to the patients, is because we need to make efforts to make data available and artificial intelligence available for the whole world. Because we're facing different problems in North America compared to South America, Southeast Asia, and Africa. And when we talk about artificial intelligence for global health, some problems are much easier to be tackled, like access to care. So there's limited access to care, workforce development, access to equipments, access to drugs, and access to data collection. So we have a lot of challenges to do that, and some of the challenges are common to the global compared to North America, including education, so AI literacy, developing talents, developing regulation, promoting funding, and infrastructure. And we are doing some work on that. So we are working, trying to train the next generation of students globally on artificial intelligence. So we are actually promoting some studies. We published some articles at Nature, and we also promoting some courses for people in the Latin America region. So here I'm going to discuss some cases of success of applying some analytics to big data. So this is one of the first projects that I got involved with some colleagues from all over the world. So it's about developing a new classification or stage system for prostate cancer. So we were able to bring together about 20,000 patients from 55 centers, and we have a major effort to also have 2 external validations data set. We end up having more than 1 million unique data points, and in the end of the day, we were able to develop 9 unique groups that are compliant with AJCC staging guidelines. So this is now being reviewed by AJCC here in North America to become the new staging for prostate cancer. And interestingly, we were able to bring data from all over the globe. So we have data from Canada, from US, from Europe, from Latin America. It's still lacking some data from Asia and from Africa, but it's much better than the previous staging system that first was based on expert opinion or only data from North America. So this is a way that we can use technology and machine learning to impact the world. Another project that we were able to enroll, and this project I'm very happy to present because I was able to mentor a student to learn how to deal with this kind of data and to apply some methodology. So we were able to create some signature to describe prognosis and need for treatment or not on patients with oligodendroglioma. So using CBioportal TCGA data, so we look at some hypoxia signatures from RNA, and we are able to predict 2 groups. One group that would benefit from radiation oncology, from radiation treatment, and the other group who would not benefit from radiotherapy. And then we were also able to validate these findings on our own data set when I was in Toronto. More recently, we are trying now to build a model to predict survival on the time of brain metastasis by using radiomics and machine learning on MRI imaging. So our model is getting more accurate, and we are getting now close to have a potential to deliver a high accuracy on survival, which will help our patients so they understand better their prognosis when they have a diagnosis of brain metastasis. Because nowadays it's still a stigma. When you tell a patient that they have brain metastasis, they lose their ground, correct? So now we are trying to help them understanding and predict the future. And that will also impact on follow-up schedule and treatment options. So also will support the healthcare system. We also, this is some projects on segmentation. So using AI to help us with contouring, and that will is reducing variability and also making the process of contouring on radiation oncology more efficient. Also improves time, and as I said, and also improves accuracy. This is a work from colleagues from Toronto that's now going to be expanded to Latin America. So using AI to promote automatic planning. As you know, we don't have enough human resources in low and middle income country. So actually having artificial intelligence helping them to plan complex cases in radiotherapy has a major impact. And they were able to prove in a prospective study in Toronto that artificial intelligence can reduce radiotherapy planning process times and efforts in 60%. So that will be very helpful for our colleagues down the globe. So some other applications in oncology, especially on process improvement that I'm going to discuss now. So the first one is a simple artificial intelligence realistic system that we deployed in the largest cancer center in Latin America. So what we did is that in Latin America, we have the largest cancer center, which is about 22 floors. It serves as a population of 20 million people from the city of São Paulo. The hospital usually opens at 7 in the morning, and before the hospital opens, there is already a lineup of about 800 people waiting outside. And you could imagine the nightmare when they open the doors for people to go to their consults, to their imagings and blood. So usually they would wait in average 30 minutes, but that could range up to 1 hour and a half just to have the first encounter with the secretary to get the labels and then to be directed to their own clinics or imaging system. So what we did an automated system with robotic logic, and now the patient just go, there's like 10 benches with computers. They just put their identifiers. They'll come on agenda with all the appointments that get printed, and then the patients just go ahead to their appointments without losing, like I would say, less than 1 minute of their time. So that's improving patients and bringing better quality care to our patients. The next step that we are implementing now, it's making sure that all this information, here is the process, the print labels. So now everything goes through the electronic health records. And after the patient is seen in a consult now, he gets a message, and a message is with a link that tells the patient when is his next appointment, what are the next imaging needed. That's saving time to the patient, organizing their care and journey, and saving the doctor time, because now we don't need to fill any paperwork after the consult is done. We get the information from the EHR, and the patient can go home, and the doctors do not need to fill any other paperwork. Some examples of global ecology. So I also want to highlight the database that we are building in Brazil. So there's an ecosystem that we are developing. So now we have I would say like a data lake with a lot of public available data of populational data on patients with cancer. So here first, how the database work in Brazil. So Brazil is a mixed healthcare system where 75% of the population is covered by the public system and 25% by the private system. So we have data on almost everything for the Brazilian population, for the public system, going from drug consumption to medical claims to electronic health records. So what I want to highlight is that now we were able to collect all this database together to create a data lake on a protected system. So we have access from all like the 5 major databases of the country. So we include like from basic information from mortality and outcomes to more specific information regarding information from hospital admission, ambulatory drug use, treatments, and other data. So this database now is covering about 75% of the population, so about like 150 million people. So we have data from all these patients' outcomes, and we also have data on social determinants of health, including age, gender, ethnicity, where the patients live, income, and many other important information. So this is a potential area that we can all collaborate and we can all build on that. There's also another database from state of São Paulo. So state of São Paulo, about 30 million people. So this is a prospective public cancer registry from 76 cancer centers in the country, about 1 million patients on that database. We have data on age, like treatment, tumor histology, staging, educational level, like many important data for us to understand these patients and to do great analysis with this data. And here we are creating this database, and I'm just gonna show some of the data that we have been working. So for instance, with anal canal cancer, stage 1 to 3, we were able to find 1,462 patients with a median follow-up of 6 years. So we have like social determinants of health for all these patients. So glottic cancer, about like 1,000 patients, and we have a lot of data that can be studied and can be analyzed as well. Brainstem glioma, about 260 patients, only from that database. And we can also apply both databases, the data source or the bigger database for the full population with the state of São Paulo database for global good. So we did this study where we created an index, a shortest to radiation facilities index. So that was meant to help and to support pre-authorization of new radiation linear accelerator in Brazil. So we were able to rank all the states, and then after ranking all the states based on number of cancer, incidence of cancer, access to treatment, we're also able to validate with our public database where we need more access and how we could promote access to radiation treatment. And we are now doing that in a global scale, and we are gonna show how we can improve access to cancer using the global direct international agency database. So that was what I was planning to highlight for you today. And in conclusion, we understand that healthcare is under pressure, that patient-centered care, data, and innovation are the drive force for the future of healthcare. Artificial intelligence is growing, but it's still like far from clinical. We have a lot of opportunities to make major health process and clinical impact, but we need to focus on generating evidence, supporting places in need, and teaching the next generation. Thank you.
Hello. Yes. I'll deliver.
Thank you so much.
I'm not used to such personalized care. By way of introduction, I'm a cancer doctor as well. And so I wanted to, I know you touched on a few of these in your slides, few points about real-world studies. And what I'm interested in is, first of all, your talk was great. It was a really great presentation. There's a lot of creative tension between the conduct of randomized clinical trials and real-world studies, and there's almost an entrenchment of opposing views. What do you see the future of interdigitating real-world studies versus employing randomized clinical trials in order to interrogate questions in the clinic?
Yeah, thank you for the question. Great question. So yeah, there has been like a lot of discussion, and I think like last year on our annual meeting there was like a very heated like discussion about like quitting clinical trials and only doing like real work. I don't see that being the way to go. I still think we need clinical trials, and clinical trials are of major importance for many questions. One thing that I like about real world evidence is that as evidence is changing so fast and we're evolving so fast, we're able to see how things are going to change on practice and how they're impacting patients, because we know in clinical trials we have like the Olympians, correct? The best players are the ones who are selected, and sometimes the results that we see in clinical trials might not translate to the real world. So the future I see is us like together as a community building big prospective populational database that we can see new interventions, new technology being deployed, and what is the real outcome in the world that we live outside a controlled environment. But clinical trials, they still have a role. They are important, and they will still like have a role in the future for sure. I think there's people online, so.
So I would agree with your view if I could just ask a follow-up question. So I think the idea behind real-world studies is to interrogate questions that wouldn't be evident in a randomized clinical trial, kind of unlocking hidden information. What are the barriers to doing that, to unlocking, from your point of view, all the information's hidden in the medical record?
So if I'm getting correct, like what is the barriers to have like a real world evidence available? Yeah. So I feel like in Brazil, for instance, and then I can compare to other countries, I can show you like the big barrier is that when you have 30%, 25% of the population relying on the private sector, so most of the time these hospitals, they are not willing to share their information. So they keep their information in silos, and then all the follow-ups, diagnosis, and etc. is hosted on that institution. So the patient is actually not owner of the data. The patient is the owner of the data, but in the world that we live now, they don't have like control on their data. We say they have, but they don't have. So we need to improve that, number one. So we need to move as the bank. They move to open banking. We need to go to open healthcare, where the patients will be the guardians of their own information, and then we'll be able to understand their journey, their outcomes, and then use that as a way of producing evidence for the future. So that's number one for me. It's one important point. The second point, there's always the discussion about like consent form, how this is gonna work with multiple institutions, how we're gonna collaborate, and who is gonna be like leading it, because that's the way that academic promotion works, who's gonna get the grant, who's gonna be the first author on the publication. So there's also these other barriers that when we look in public system, like we have in Canada, where we have the Ontario database that Michael presented yesterday, we have access to the full province data, and anyone can access and inquiry like questions to that like populational database. And the same happens to Brazil. These data sets, they are publicly available for any researchers. There's no Russells, there's no paperwork, there's no politics. You just bring your question, we can get the data out, you answer your question, we improve outcomes, we improve the health process to our patients.
Thank you.
Thanks, Fabio. That's a great talk. So this group, or many of us, came together as part of the Moonshot Initiative, right, which is a NCI, Department of Energy thing. Big vision, blue sky. And one thing I really appreciate about the ground shot is that it's focused on taking what we already know about cancer and rolling it out to the whole population, right? If we really wanted to move the needle on survival of cancer, we would just make sure that everybody has access to treatment. We would make sure that those assays and tests are super cheap so every medical center can run them without a state-of-the-art genomics facility, for example. And so I wonder, like that was kind of buried in everything that you were talking about today. You've got this experience in Brazil. So like what's your thinking about this ground shot idea?
Okay. Yeah, no, that's perfect. So I couldn't spend much because of time, and like I was trying to cover a lot of stuff as well. So for me, it's of major importance for us to focus on ground shot. So we need to focus on delivery, what is available to everyone. And when we talk about inequalities, it's not only inequalities in low and middle income countries. There is inequalities here in North America, in the US, in Canada. So not everyone has access to the same level of care. Not everyone has access to like new drugs, new like diagnosis technology. That's important for us to move the field, but like in the present, we need to make sure that everybody has access to the minimal standard of care when we are dealing with cancer, because we are seeing a lot of improvements on survival, like new drugs. But for instance, in Brazil, like it was not like, it was just like recently that we starting doing like tumor profiling in some centers. So meaning that majority of patients, they don't have actually any kind of molecular profiling, so EGFR, ALK, PD-L1. So we actually, if someone is running a clinical trial in Brazil testing a new drug for a target, doesn't really matter because patients in Brazil will not have access. So that's the big point. And that's with the majority of the globe. So if you look for in China, if you look in India, Southeast Asia, where the majority of the population is, they might never have access to these new technologies like liquid biopsies, like genomics, and et cetera. So I think that's the important. We need to bring the basic to everyone, so then we can actually like shoot to the moon.
So I'm very intrigued by what interoperability model would go from São Paulo all the way to Canada and maybe to the open health. So is this something like a UK Biobank and Enclave where people would be vetted in? Or is there some sort of interoperability mechanism that is emerging in these efforts?
So can you reframe like?
Sure. So you have many, the IT layer in these places is very different. They have different APIs. Some of them won't have APIs at all. So how would you be able to come up with an AI solution and then deliver it in a place that is defined by the stakeholder, being it, say, in Canada or Brazil? Because I assume it would be the same model that could be plugged in both systems. So how would this be achieved?
Yeah, so I'm not sure. I'm not the best person to answer that question, how we are gonna make that happen. So ideally, like we'll need to work with like our IT team or with someone who is more expert on us to develop ways of bringing this all together. The first thing that we are doing in Brazil, so the first effort, so what we made is that now we have like a centralized way of collecting all the data from all these 76 hospitals. So we have actually, we start with like a paper form, now it's an electronic form, and they all are different systems. So there's a team there in Brazil that works together to make these connections and to promote the interaction, and then all the data will go to a lake, and then as soon as they get to that data lake, the data is a raw, unstructured data that we can just like query questions and bring them out. So then how we are going to move that to other countries, that's a big challenge because there's different rules, different ethics frameworks and policies and etc.
Thank you.
Thank you for your presentation. I have 2 questions around value. The first one, just your perspective on the opportunities available to collect data from the non-standardized care settings, for example, the traditional settings, as we venture into these lower to middle income countries. Any efforts, especially in Brazil, in that context, in aggregating data from those settings and the value and insights that could be gained from those. And then the second one was regarding the educational partnerships that you have. Any challenges and also the types of credentials that the students or participants have at the end of your interaction with them and the recognition of those credentials.
Okay. So number one, regarding data, when we talk about data collection, and then I'll give Brazil an example, like as I said, like 80% of the population relies on the public system. And the public system, you have like, as Amber showed yesterday, you have a single card with a single number and identifier that tracks all your visits. So it doesn't matter if you go to the oncologist specialist or to your family doctor or to a radiology service, that data will go all through a central database at the Ministry of Health. So it's easy for us to aggregate that data and to collect that data on different levels. The challenge is the quality of the data. So there are still like a lot of places that they do handwriting charts. So then you need to rely on the will of the people working there. One, to have like nice letters that someone can read. And 2, they need to scan that documents and send the documents to the central. And sometimes that can take like 6 months to 1 year for a data to arrive. And then when the data is arrived, the data needs to be curated. And then when that data is curated, it's then like inputted on the database. So you can lost information there. You can, like when you are translating the real world data to the database, you might be missing some information there. So that's number one. Number 2, regarding training, so what we're doing like partnership with big institutions in the country, and we're majorly aiming to teach people. First, we start with medicine, so medical students, and now with students on the healthcare system, or any other allied professionals. It's not a degree, there's no credential, because I'm a big believer that certificates on the wall, they don't matter much. What matters is like the skills that you acquire, and if you're able to apply that skills to improve any process, to improve outcomes, to improve access, or etc. So we have discussed about bringing like a degree within a big university, but at this point we are just doing like a training course to generate the next wave force of people that will help us to change or to shape the future of oncology in the country.
Can you hear me?
Yeah.
Yeah. Okay. Great. Thank you for having me this morning. Real pleasure to be here. So I want to talk about the work that our group has been doing. I should also mention that we just transitioned to Emory University about 10 weeks ago. So the majority of the work that I'm talking about here really was work that we did at Case Western Reserve University, where we spent between 2012 to 2022, so spent a decade there. And the work that our group has been interested in is really looking at the role of artificial intelligence across different length scales from the perspective of precision medicine. And so I was inspired by the book by Siddhartha Mukherjee called The Emperor of Maladies, which if you haven't read, I highly recommend. A fantastic chronology of the history of cancer. And so I was inspired by that book, and I thought that, well, what is an apt title for the talk? Well, if cancer is the emperor of maladies, then, well, potentially AI is the interpreter of all maladies. So that's my conflict of interest disclosure slide. I just want to call out Picture Health, which is a company that I recently founded. I've got an equity stake in, and that also licensed some of the technologies that I will touch on over the course of my talk. But I will say that my true disclosure is the fact that I have a social media account. That's my Twitter handle. If any of what I present today is remotely appealing and you are on social media, please feel free to give me a follow. What? Excuse me there, just 1 second. I apologize. Sorry, wrong slide. Yeah. All right. So what I really want to start out by talking about is this issue of overdiagnosis and overtreatment of cancers. And some great data coming out over the last couple of days, if you've been following the news, that there's been a significant reduction in cancer mortality, certainly in the United States, which obviously is fabulous news. But if we're being completely honest, we have to acknowledge that what has happened along with this reduction in cancer mortality is the fact that we are still overdiagnosing and overtreating a number of cancers. And perhaps a great example of that overdiagnosis and overtreatment of cancer is in prostate cancer, a disease that affects 1 in 7 men in the United States. Yet only 1 in 40 men will die on account of the disease, and yet we tend to treat these cancers very aggressively. Most of these men, even with indolent disease, are treated with radical prostatectomy, surgery. A number of them are treated with radiation therapy for disease which in many cases could very well have been left all alone. And there are some very real toxic effects of those treatments that are felt by the patients. But beyond the toxicity on account of radiation or the side effects of radical prostatectomy, we also have to acknowledge, at least in the United States, that we have the very real issue of financial toxicity. We know that about 42% of new cancer patients will lose their life savings, many of them within 1 year of that initial cancer diagnosis. And so our group's really been thinking about how could we leverage the plurality of data that we are routinely acquiring for so many different diseases, using standard of care data, primarily imaging data, with AI-based tools to try to address this issue of both patient-centric toxicity, but also this issue of financial toxicity. In other words, how can we develop low-cost tools that work with standard of care data to be able to sort of really realize this promise of precision medicine? And I want to just start off by acknowledging the plurality of data that we're acquiring. And here's an example in the context of prostate cancer where you're looking at a T2-weighted MRI scan of a prostate, and that region in the white square represents an area of adenocarcinoma. Now, with a multiparametric MRI scan that is now being done more and more routinely for men with elevated PSA, you can actually acquire different parameters that capture different attributes of the tumor. Assuming this individual goes on to get a radical prostatectomy, that pathology specimen can be digitized using whole slide scanners. Tom will no doubt talk more about this. But with that digital pathology image, one can start to interrogate subtle patterns relating to the cellular morphology and the arrangement of cells. And we can do this across multiple different scales, multiple different resolutions because of the density of the data that's embedded in these digital pathology images. But we're also acquiring omics-related information as part of routine clinical workup for a number of patients today. And so what we have is data that traverses multiple different length scales, from radiology to pathology down to the molecular, proteomic, and genomic level. And so the question that we've been asking is, how can we really converge all of this information that resides across different length scales? How can we interrogate the plurality of data, and then how can we converge all of this diverse information across different length scales to really develop integrated predictors that allow us to not just identify disease presence, but also try to address the issue of prognosis and therapeutic response. And so that's really the premise of the talk. What I would like to showcase today to you are some examples from our work where we're using artificial intelligence not just to address the issue of diagnosis, and I'm sure Tom is going to talk about the wonderful work that he and his team have done for prostate cancer detection. But I want to talk about that issue after the cancer diagnosis. 40% of the US population is going to be diagnosed with some form of cancer in their lifetime. How do we manage these patients? And what we believe is that with AI, with standard of care imaging, we can make some significant inroads, not just on the diagnostic side, but being able to identify the severity and the aggressiveness of the disease. In other words, create better prognostic tools. But more critically, from a clinician's perspective, being able to predict therapeutic response and therapeutic benefit. We know that a number of therapies that are administered today, while they may work in a small subset of patients, do not benefit all patients. We know that we're also, like I said, over-treating a number of patients. And so we've been looking at the use of these AI tools to develop prognostic predictive algorithms and risk calculators for tailoring therapy for a given patient based on their specific risk profile. But as we're building these tools for precision medicine, we have to acknowledge some of the various different issues that have come up in the course of this workshop and that are really critical. So as we talk about clinical decision support, we have to talk about interpretability, because a lot of the tools that we currently have today are black box or opaque, or at the very least, translucent. And so we have to think about what are the kinds of approaches that we need, not just from a regulatory standpoint, but ultimately that are going to be used by the clinician to change or modulate therapy. We need to talk about reproducibility. We know that the data is going to vary when it comes from different scanners, different sites, different labs. And so how are we going to address, how are we going to develop tools that are truly robust across these different labs and different scanners? And then finally, the issue of equity that we heard a lot about yesterday. So I'm going to talk about some of the work we're doing to try to really understand whether these tools will really work across different populations, and they don't work equally well across different populations. What can we do in terms of creating more tailored AI-based models for specific populations? So I want to start by talking about model interpretability. And of course, today, I think deep learning has sort of become synonymous with artificial intelligence. I'm sure everyone in the audience is aware of deep learning. This is an example of some of the work that we published on about, now it's hard to believe, just about 6 years ago. But this was really one of the early papers on the use of a particular kind of deep learning, a stack sparse autoencoder for a very simple task of detection of nuclei on pathology images. And what we did, this is about 5 or 6 years ago, where we trained an algorithm with a series of annotations of nuclei that were provided by a pathologist to this neural network. And the neural network then learned the representations associated with those annotations, and was then able to identify this precise location of those cells, of those nuclei on new images. And so while this is a very powerful algorithm and a powerful methodology where it requires a minimal appreciation or knowledge of the domain, really, this was trained by a graduate student who knew nothing about pathology, but was able to work with a pathologist to get the annotations provided to the network, train the network, and the network did the rest. While it's very powerful that you don't need a deep knowledge of the pathobiology of the disease or anything about histopathology, the challenge is the lack of interpretability, because the representations that the network learns are fairly opaque, And that's why these algorithms very often, like I said, are referred to as black box or mysterious machines. And one specific example from our own work from about 4 years ago, where we were working with the University of Pennsylvania to try to predict risk of heart failure based on endomyocardial biopsies. And so we started this project where we got a series of digitized endomyocardial biopsies from the University of Pennsylvania, and we trained a neural network to identify whether or not there was the presence of heart disease in these endomyocardial biopsies. And so when we got the initial tranche of images, we had about 100. We used that to train the algorithm, and then we got another 100 images that were set aside as independent testing. And so when we ran it on the independent test cases, the algorithm did amazingly well. We had a 97% area under the curve in being able to distinguish heart failure from not. And just to make it interesting, we also had 2 cardiac pathologists look at the exact same set of cases. And it turned out that the pathologists came back with an average area under the curve of about 74%. So there was about a 23% differential between what the network was able to do and what the humans were able to do. So we were ecstatic. I mean, we got, we put out a press release, and the story went viral, I guess. And it was all wonderful until a couple of months later, we got another tranche of images from the University of Pennsylvania, so same demographics, same lab, same scanner. And when we ran this next tranche of images on the network, the algorithmic performance went from 97% down to 74%. And after several months of trying to figure out what had happened, we ultimately realized that the slide scanner that had been used to digitize the images had a remote software upgrade, a cloud-based software upgrade applied to it that probably perturbed the appearance of the images ever so subtly. So from a visual perspective, it didn't really make a difference, but the images had changed ever so subtly, and that change was enough to upset the network. So this perturbation had caused, had sort of catastrophic consequences, if you will, and so the prediction had dropped from that 97% down to 74%. And a classic example of where using a more opaque model really challenged us in our ability to figure out why the network wasn't performing or what had really caused it to underperform so dramatically. And so I'd say over the last several years, we've been thinking about deep learning in a slightly different way to do what we're calling deep phenotyping. In other words, using deep learning to really go in and identify hallmarks of the disease, of the tumor on routine radiographic images, to be able to segment out the tumor, to segment out the peritumoral region, to be able to segment out the tumor-associated vasculature. So the way we're using it is really to create a very granular, accurate segmentation of the tumor and the associated habitat on radiographic images. And we're doing similar things on pathology as well. So again, using the neural networks to go in and segment out different tissue compartments on routine H&E pathology images, to be able to segment out the stromal compartment, the epithelial compartment, to segment out the lymphocytes, the cancer cells. And so what we're getting with the deep learning is this very deeply phenotyped data, both radiology and pathology. And having done that, we can now start to prize out features that are more interpretable. So for instance, on pathology images, we can start to look at the spatial statistics associated with the interplay between lymphocytes and cancer nuclei. We can start to look at the spatial relationships, spatial distances, and translate all of that into interpretable digital features that can then be used to address issues around outcome prediction, but also drug response and therapy response predictions. And so this is a very quick snapshot. I'm not going to go through all the various examples, but just want to give you a quick snapshot of the kinds of problems that we're now addressing, where we're looking at a variety of different types of cancers, looking at both the radiology and the pathology images, patients treated with different types of therapy, chemotherapy, immunotherapy, combination therapies, and looking at the utility of these more interpretable features to be able to predict outcome and predict treatment response. So what I'd like to do over the next few slides is get into some very specific examples, and I want to start off with breast cancer. One of the problems our group has been working on has been to try to figure out if there are low-cost ways, easy, efficient ways in which we can predict which women with early stage ER-positive breast cancer are going to benefit from adjuvant chemotherapy. And this is a big conundrum, a question in the context of breast cancer. And about 20 years ago, Genomic Health developed a test called Oncotype Dx, a 21 gene expression-based assay to help identify which early stage ER-positive breast cancer patients could safely avoid adjuvant chemotherapy because surgery and hormonal therapy were going to be sufficient for their particular cancer. In other words, there were women who had less aggressive cancer and women who had more aggressive cancer who needed the more aggressive treatment or the chemotherapy. So the Oncotype Dx assay came along and really changed the way oncologists were starting to treat ER-positive breast cancer patients. If you had a high score from the Oncotype, essentially it reflected a more aggressive breast cancer which you needed to administer chemotherapy for. On the other hand, if you had a low score, then these women could possibly avoid more aggressive treatment and might be candidates for surgery and hormonal therapy alone. One of the challenges with this test is that it's tissue destructive. It's also an expensive test. It's over $4,000. So when we think about low middle income countries, this is a test that is above and beyond the practicality of a lot of those markets. If you look at India, for instance, which is where I was born and grew up, it's a country where the cost of chemotherapy is about $2,000. So to essentially have a test that costs twice that amount, tell you whether or not you need chemotherapy really doesn't make practical sense. And so about 14 years ago, our group working with Sridhar Ganesan, a breast oncologist at the Cancer Institute in New Jersey, along with Mike Feldman and John Tomaszewski, who was then at the University of Pennsylvania, we started to look at routine biopsy images and to ask the question, could we use machine vision and pattern recognition of routinely acquired biopsy or pathology images to try to come up with predictions of outcome? In other words, could we create an image-based test that is able to recapitulate what these more expensive tissue-destructive genomic-based tests could do? And the beauty was that we were not disrupting the clinical workflow in any way. We were digitizing these pathology images, applying machine vision to these slides, extracting the features, and then using it in both a prognostic as well as a predictive way. But the critical piece that we recognized, we felt that was going to be important for a clinician to make that decision about to treat with chemo or not, was going to be interpretability. And so very deliberately, our group is really focused on features that are more inherently, intrinsically interpretable, and I want to give you a few examples. This is from work we published last year, where Haojie Lee, a graduate student in my group, was looking at collagen architecture from routine H&E images. And we've known that collagen architecture is implicated in outcome and metastasis of cancer. And so what we did in this particular study was to use machine learning to go in and first segment out collagen, but also the tumor nests in the image. And essentially, we were able to ascribe vectors that capture the directionality of the collagen fibers in these images. And so what that allowed us to do was to come up with metrics that gave us a sense of the arrangement disorder of collagen on these H&E images. And what we found was that when we were looking at patients with short-term survival, these collagen fiber, the orientation of the collagen fibers were all more or less in the same direction. It was very coherently organized compared to patients who had better survival, who had more favorable prognosis, where the collagen architecture was more disordered and more chaotically arranged. And so Haojie was able to borrow a concept from high school physics, namely the concept of entropy. And if you think of entropy, entropy really captures the amount of disorder in a system. And so she was able to apply this concept of entropy to looking at the order or disorder with respect to the collagen fiber orientation. And we were able to create a metric that now allowed us to prognosticate outcome in these early stage ER-positive breast cancer patients. One of the things that was somewhat counterintuitive was the fact that collagen was more coherently arranged in patients who did poorly and was more chaotically arranged in patients who tended to do well. And this, while initially appeared counterintuitive, started to make more sense when you start to appreciate that collagen has been implicated as a cancer promoter. It's been implicated as a vehicle for promoting metastasis. Because if you think of it, if collagen is the highway that allows for migration of cancer from the primary side to secondary sites, the more ordered that highway, the easier it is to promote that migration. On the other hand, the more disruptive, the more disorganized it is, the more it is likely to prevent or inhibit the likelihood of migration. And so we were able to validate this approach on patients both from the TCGA as well as a completed clinical trial data set, ECOG 2197, which is now nearly 3 decades old. And so that was one example of how we could use these interpretable features from a prognostic standpoint. But perhaps what was even more exciting was this data that we generated, where we went back and looked at patients who had had the Oncotype Dx test. So remember I said that with the Oncotype Dx, if you had a low score or you were deemed to be low risk, then chances were that you could avoid chemotherapy. On the other hand, if you were higher risk, then chances were that you probably would need the adjuvant chemotherapy. What we did was to look specifically within these different buckets. We looked at the low oncotype and we looked at the high oncotype. And within the low oncotype, the image-based features identified a distinct subset of patients who actually had worse outcomes, suggesting that even though oncotype might have suggested that all of these patients could avoid chemotherapy, there's clearly a subset of patients that was picked up by the image classifier where they probably, in hindsight, should have received adjuvant chemotherapy. Of course, these are all retrospectively treated patients. On the other hand, when you look at the high Oncotype Dx category, the image-based classifier was able to identify a subset of patients who did really well, suggesting perhaps that in hindsight, these patients could have avoided the adjuvant chemotherapy. But it's not just in breast cancer. We've similarly been working in the area of prostate cancer that I alluded to a few slides ago, where in prostate cancer, a number of men get radical prostatectomy, but some subset of these patients will likely have a recurrence of disease where the disease will metastasize. And so the question we've been asking in the context of prostate cancer is, could we look at patterns from the surgically excised specimens and figure out the risk of recurrence of the disease post-surgery? And here we've been looking at the spatial arrangement and the spatial architecture of glands on these radical prostatectomy specimens. And what we found is that the spatial arrangement and the spatial architecture of these glands is quite different between patients who tend to have a recurrence of disease and patients who don't have recurrence. And in fact, we've shown on a fairly large cohort of patients, this was published last year, where not only could we look at prognosticating risk of recurrence post-surgery in these patients in all comers, specifically in patients where we had margin negative patients. So these were patients where there was no evidence of disease on the periphery of the excised specimen. Those patients who are typically considered to be low risk, even in those patients, we were able to identify a distinct subset of patients who actually had worse risk, who had a recurrence of the disease, suggesting that this image-based risk score could really complement the clinical pathologic factors for better stratification of disease. Now, I talked about the Oncotype Dx test in the context of breast cancer. Now, the equivalent test, it's a 22 gene expression-based assay for prostate cancer, is the Decipher test. And this is a $3,000 test to predict risk of metastasis in the context of prostate cancer. So in a relatively smallish cohort of patients, there were about 167 patients, we went head-to-head with the Decipher test. And what we found was that when you looked at the image-based features from pathology alone vis-a-vis the Decipher-based test, the 22 gene expression-based test, there was equivalence, there was non-inferiority. The image-based features did just as well as the Decipher-based test. But then what we did was we took the image-based features and combined it with two very standard clinical pathologic factors. We looked at Gleason score, Gleason grade, Gleason score, and we looked at preoperative PSA, which is the prostate-specific antigen. And when we combined just those two features with the image-based score, we found that we were able to now do significantly better, in fact, compared to the Decipher test. The hazard ratio was almost twice what we were getting with the Decipher test. So the question is, well, why does all of this matter? Well, it matters because, like I said, from the perspective of global health, from the perspective of low middle income countries, cost matters. And so when you look at these genomic-based tests like the Oncotype, like Decipher, You appreciate the fact that these tests cost $3,000 to $4,000. The question is, what can we do in a resource-strapped setting? Could we look at just H&E images and use these kinds of predictors at much lower cost to be able to modulate therapy? The other piece is the efficiency. Can we do this quicker, faster? Because we're not physically shipping tissue around. We're not destroying any tissue. And therefore, could we have global impact, and not just in the US or North America, where the technology exists to be able to perform these tests? Or as I like to think of it, can we create an inexpensive, fast, reliable, accessible prognostic cancer test that's priceless for everything else there's MasterCard? All right, what about radiology? So with radiology, we've been, again, trying to find patterns and features from routinely acquired radiology scans like MRI or CAT scans that, again, identify subtle features or subtle patterns that are both interpretable, but are also what we call subvisual, where we can find subtleties in the disease appearance that go above and beyond what a human might be able to discern from the scans. And I give here an example of work we've done in the context of brain tumors, specifically GBMs, where GBMs, of course, are treated with chemoradiation, and when they come back for a follow-up MRI scan, very often something shows up on that MRI scan. And the question now is that flare that shows up on the MRI scan, is that a recurrence of the tumor, or is that radiation necrosis? Radiation necrosis being essentially an effect of the radiation therapy. It's benign. But because they're so difficult to discern on an MRI scan, very often the follow-up is an intracranial biopsy, which is obviously very invasive, it's expensive, and it's traumatic for a patient who's just undergone treatment for a brain tumor. And so we developed an algorithm that essentially looked at spatial patterns of the edges. So if you think of the images, if you think of every pixel in the image, it's surrounded by 8 other pixels. And one can compute the edge or derivative of the center pixel with respect to all the pixels around it. And it turns out that, again, one can identify the dominant edge. Just like with the collagen architecture, one can identify the dominant edge or dominant gradient at every voxel. And again, borrowing the concept of entropy, we're able to create disorder maps like the one that you see here. And what you're seeing is essentially a reflection of the degree of heterogeneity or the degree of disorder locally across the entirety of the MRI scan. So the left panel shows a lot of red, in turn reflecting a great deal of morphologic heterogeneity. The right panel, on the other hand, by contrast, shows a much lower degree of heterogeneity, a much lower degree of entropy. And it turns out that the more heterogeneity, the more entropy that's associated with the tumor recurrence. The lower the degree of entropy or heterogeneity, the more likely it is to be associated with a benign condition, in this case being radiation necrosis. And so again, I come back to this theme of interpretable features, features that resonate with our understanding of the pathobiology of the disease. This is work we did with Ash Tiwari's group at Mount Sinai, where we were looking at MRI scans of the prostate to try to understand, was there something about the shape of the prostate that could portend the risk of biochemical recurrence? So we looked at a cohort of patients that had biochemical recurrence after surgery. We had their MRI scans. We had another cohort of patients where these patients did not have biochemical recurrence after surgery. We were able to create a statistical model of the shape of the prostate in patients who did and did not have recurrence. We then did a difference procedure where we really created a difference atlas between the two populations and identified distinct areas that were differentially distended between patients who did and did not have recurrence, and so identified hallmarks on the surface of the prostate as well as within the transitional zone that were differentially distended or deformed in patients who did and did not have recurrence. We were then able to use patterns of this distension feature to be able to predict risk of recurrence in these patients based on a preoperative MRI. One of the other features that we've been very interested in is really trying to understand the tumor milieu, the tumor habitat. It's not just what's happening in the tumor, it's what's happening around the tumor as well. This is a paper that we just published. This just came out last month in Clinical Cancer Research, where we were looking at breast cancer patients who were receiving neoadjuvant anthracycline. And the question we were asking was, could we look at a baseline MRI scan to predict pathologic complete response in these patients? So when they go to surgery, can we predict whether they are going to have no disease present, or are they going to have the majority of their tumor still present on the specimen? And in this particular case, rather than looking at the attributes of the tumor or textual patterns within the tumor, we actually focused on the tortuosity and the convolutedness of the vessels associated with the tumor. And what we found was that patients who tended to have a pathologic complete response, the vasculature was smoother. Patients who did not have a pathologic complete response tended to have a much more twisted, much more convoluted vasculature. And so again, a more interpretable feature that was also associated with treatment response. The last few minutes that I have, I want to go through some of these other attributes that I mentioned. Reproducibility, which I think is a really critical issue that we don't perhaps talk about as much, particularly from a quality assessment perspective. About 4 or 5 years ago, Andrew Janowick, who was then a postdoc in my group, now research faculty, was reviewing a series of papers, and he came to me and he said, Anant, I'm looking at all these papers that are coming through, and they're looking at images from the TCGA. And they're reporting all these statistics and all this data from the TCGA, but I've been looking at these, and I found several issues, several artifacts with a lot of these images. And so we went back and started to visually try to identify the artifacts and found there were a lot of images that were really compromised, that these images, there was absolutely, they had, should never have been used for developing AI or applying AI tools. And so Andrew then decided, well, what we really needed was a way to to check the quality of the images prior to applying AI-based tools. And so we developed something called HistoQC that we made completely available for free for research use. You can download it from that link below. But essentially, it's an algorithm that allows you to ingest a whole bunch of digital pathology images. You're then able to get a score based in terms of a number of different quality metrics on a slide level as to whether this is AI-worthy or not. But more critically, it can also identify particular regions within the pathology image where you do have the integrity needed for application of the AI tools. But the other piece of all of this is identifying features that are not just going to be discriminating, but are also going to be stable. And so one of the things that our group has been doing has been to very deliberately and intentionally identify features from the get-go that are not just predictive or prognostic, but are also stable across multiple different sites. One of the things that we've paid particular attention to as we develop our training sets is to make sure that we're including data from multiple sites, representing data from multiple scanners, multiple different labs, so that we have the opportunity to not just look at features that are most predictive or most prognostic, but also those that are going to be resilient and stable across different sites, across different labs. And so by doing that, we've shown this intentionality up front allows us to create more generalizable, more robust classifiers that tend to work on new unseen data in a more rigorous, robust way. It also brings my next point, segues into my next point, which is about the importance of inclusion of different sites, not just from a training perspective, but also from a validation perspective. This is a paper we published in the area of head and neck cancers, where we were looking at a very simple feature, again, a very simple interpretable feature from pathology images using machine vision to be able to prognosticate outcomes, specifically in HPV-associated head and neck cancers. And one of the things that we were very deliberate about was to demonstrate that this feature was going to work across a plurality of sites. So we spent a lot of time. This work took about 3 or 4 years to pull together. But you can see with the author list, there were a number of different sites that were involved. We had over 1,000 patients in the study. But the feature itself was relatively straightforward. It was a feature that pathologists have long recognized as being a hallmark of poor cancer biology in head and neck cancers, also called multinucleation. And so we demonstrated that using machine vision, we could identify this multinucleation motif on H&E images. We validated this across a plurality of sites and demonstrated its association with outcome and disease-free survival across multiple sites, and showed that particularly in stage 1 and stage 3 disease, this multinucleation feature was strongly prognostic. In just keeping with this theme of interpretable features, another feature that we looked at has been around tumor infiltrating lymphocytes. So we know that TILs, or tumor infiltrating lymphocytes, are strongly implicated in treatment response and outcome for a number of different cancers. But most often, the feature that pathologists tend to look at is the density of TILs, or the number of lymphocytes. We took a slightly different tack. Instead of just counting the number of lymphocytes, we focused on the spatial interplay between lymphocytes and cancer cells. And so we created spatial statistics that looked at the cohabitation and the proximity of TILs with respect to cancer cells. And again, in the context of head and neck cancers, showed that these spatial statistics that looked at the relative proximity of these cancer cells and TILs with respect to each other was strongly prognostic of outcome. And again, you can notice we had a number of different sites that this was validated on. We looked at the association with different clinical pathologic factors and demonstrated in a multivariate setting that this feature was independently prognostic. Again, I want to sort of just keep harping on this theme of looking at plurality of sites. This is work we published a few years ago, where we looked at radiomic patterns or textural patterns, entropy patterns of the tumor and the tumor milieu on CT scan, and showed that these features were associated with response to immunotherapy in the context of non-small cell lung cancer. Very deliberately looked at multiple different sites, multiple different agents. In this study, this was also repeated with pathology images. And we showed in a paper that just came out 3 months ago in Science Advances that looking at the spatial proximity of TILs and cancer nuclei on H&E images, that again, we could predict response to immunotherapy in the context of non-small cell lung cancer patients. And also critically, that these features were associated with response across a plurality of different agents. So we looked at nivolumab, pembrolizumab, as well as atezolizumab. Perhaps most critically in this paper, we demonstrated that when you looked at PD-L1 low patients, so again, just to contextualize, PD-L1 is a biomarker that's used for immunotherapy administration. And if you have low PD-L1, chances are you're either not a candidate for immunotherapy, or you're probably going to get immunotherapy with chemotherapy. When we looked at the cohort of patients that had low PD-L1, we were able to demonstrate that the image features were able to better stratify two distinct groups within the low PD-L1 setting. And if you look at that low-risk group, that data suggests, again, this is all retrospective data, but the data suggests that that low-risk group might be patients who are candidates for mono-IO therapy. In other words, potentially, if they were otherwise candidates for chemo and immunotherapy, maybe they could skip the immunotherapy. Skip the chemotherapy. So finally, I just want to end with equitable AI. This is something that I brought up yesterday. This was data that came out in JAMA Oncology last year, where they showed that the Oncotype Dx actually was not accurate in Black women with breast cancer. And so one of the things that our group has been studying has been to see whether we can create population-specific models to create more accurate prognostication. This is data that we presented at the San Antonio meeting last year. We have a publication that's under review, where we looked at images of breast cancer, both from South Asian women as well as Caucasian American women, and showed that there were differences within the stroma in terms of these nuclear morphometric features. These differences were then used to create population-specific models, which we then showed were more accurate in prognosticating outcome compared to a population-agnostic model. A couple of years ago, we showed that this basic approach could also be applied to create more tailored, precise models for prostate cancer recurrence in Black men. We showed in a publication in Clinical Cancer Research that if you created a population-agnostic model, that population-agnostic model was not accurate of recurrence estimation in Black men. But by creating more tailored population-specific models, we were able to create far better prognostication in Black men compared to a population-agnostic model. We've been doing similar work in the context of uterine cancers, specifically endometrial cancers. This work was presented at the ASCO meeting last year, where we showed, again, that using these approaches, that there were differences in the stroma of uterine cancers between Black women and white women. And again, creating these population-specific models resulted in better prognostication of outcome in Black women with uterine cancer compared to a population-agnostic model. And then finally, we've also been trying to understand gender specificity and whether gender-specific models might be warranted for certain diseases. This is some very preliminary work in the area of non-small cell lung cancer, where gender-specific models seem to outperform gender-agnostic models. And so with that, I'd like to conclude. So hopefully what I've conveyed is that AI with routine imaging could help address questions in precision medicine. I really want to emphasize and reiterate the low-cost aspect of these tools, which is really going to be critical from a global impact, particularly in low and middle income countries. And I think also we really have to think about association and understanding of these patterns, getting away from just looking at opaque black box based approaches. Really trying to establish an intuitive, interpretable basis is going to be critical to drive clinical adoption. And then finally, we absolutely have to make sure that we're validating these approaches across a plurality of sites, conditions, and populations. Thank you very much.
Thank you so much. We have time for a few short questions. Please go to the mic. Great, thank you.
Thank you for a great presentation. So I appreciate you're trying to use interpretable features to stratify outcomes. The question comes to my mind when people were talking about classical machine learning versus like more neural networks, where you say, I don't want to do feature engineering. I will like use all the features I have, even though you will lose some interpretability. But how much performance you're leaving on the table when you're trying to get this kind of engineered, hand-engineered features that are interpretable, but maybe you have missed other features as well that could have given you some better performance. Have you done any experiments to show that?
Yeah, so we've done a lot of that. So we've done head-to-head comparisons with deep learning. We've looked at the combination of sort of deep learning and feature engineered approaches. In general, so maybe this is my bias as a biomedical engineer, that's how I was trained. But if you think deeply and carefully about your features, if you make sure up front that the features you're developing are going to be generalizable, are going to be robust, you're ultimately going to result in classifiers that are not just accurate, but are also going to be more robust to external data and to new test data. And that's one of the things that we need to appreciate, that there's sort of this general belief that if you take the black box approaches or the deep learning approaches, you just throw enough data at the problem, these approaches will learn, and we won't have to worry about anything. They'll be robust and generalizable. Again, the part of me that's a biomedical engineer just seems to have a fundamental issue with that. And I think that one of the things that we've learned, and this is the reason I gave the example of the heart failure endomyocardial biopsies, that you may think that you've exposed it to the plurality of different parameters and conditions, but we don't know what we don't know. So you don't know what the network has not been able to learn. And so for me, what we found to have had success is the intentionality in the developing and the validation of these features up front, which is really critical. Because accuracy is important, but just as important as accuracy is that it has to generalize to new sites and new scanners. And that's really critical. And so there, I feel the interpretable piece becomes really important.
Yeah, I agree. I'm just curious if you have done an experiment
Yes,
where you
we
think
have.
the data
Yes.
has covered everything
Yep.
and say, oh,
Yep.
if I just took all the features I can get versus the interpretable, how much performance you can potentially get from just not getting interpretability?
Yeah, so I think, so what has been always interesting is that when you take the combination approach, it looks to do better on the training side. But what is really interesting, and we have the data, I think I showed it with the lung cancer work very briefly, where we did the head-to-head comparison. When you go to new sites, the intentional handcrafted based approach tends to work better. Yeah.
All right, thank you.
Sure. Yes.
I really enjoyed your presentation, and
Thank you.
by coincidence, I chaired the NIH panel that funded the Oncotype Dx trial. And as you know, that trial took 10 years roughly.
Yep.
And it was a prospective trial. What I learned in serving on that panel was the essential need for reference labs, CLIA-approved reference labs, and that in the absence of that, you couldn't have confidence in the results. So I'd be interested in your perspective then, based on what you've just shown us, which were largely retrospective analysis, not prospective. Is there a need, in order to democratize, as we all want to see, and have equitable equitable healthcare information shared, is there a need for something like a CLIA approved system where we have harmonized results across many different platforms. What's your thoughts on that?
Yeah, it's a great question. So one of the things that I think Genomic Health did really well, of course, was setting it up as a CLIA-based test and LDT. They didn't go the FDA route. MammaPrint did. MammaPrint did go the FDA route. And one of the things that I've been thinking about quite a bit is, I mean, I've been talking about this for a long time, and this is still not in the clinic. It's still retrospective validation. One of the things that we are now trying to do is to potentially stand these up as LDTs, right? So within, one of the reasons I moved to Emory was the fact that you've got Emory Healthcare and Emory that are part of Emory University. And so the opportunity to work within a system like that where we can validate or based on retrospective data, but then go and potentially stand these up as LDTs or CLIA-based tests within the Path Lab. One of the other projects that we've just recently been funded through the NCI is a UO1, where we're working with the Tata Cancer Center in Mumbai to stand up these tests there so that this can be prospectively validated on Indian women with breast cancer. And so I think that we're going to learn a lot. There are still a lot of various pre-analytic factors that we perhaps are not truly appreciative of based on retrospective data, but will only become evident in the prospective setting. And I think that's absolutely where we need to go. The LDT, I think, is one sort of way forward that we're looking at. Certainly there are potentially other mechanisms, going the FDA route and looking at a 510K and so on.
Thank you.
Sure. Thank you.
Okay, we're going to try this again. So thank you for your flexibility. We've got a few changes in the schedule now. We have Dr. Thomas Fuchs, who's going to join us. Dr. Fuchs is from Mount Sinai, and he is a scientist in the groundbreaking field of computational pathology, focused on the use of AI to analyze images of tissue samples to identify disease, to recommend treatment, and predict outcome. In October 2020, he was appointed the co-director of the Hassel-Platter Institute for Digital Health at Mount Sinai, Dean of Artificial Intelligence and Human Health, and Professor of Computational Pathology and Computer Science at the Icahn School of Medicine at Mount Sinai. In this role, he leads the next generation of scientists and clinicians to use AI and machine learning to develop novel diagnostics and treatments for acute and chronic disease. So, thank you so much.
Thank you so much. Thank you for the invitation and the very, very nice introduction. Thank you, Anand, for the talk before, and it's really hard to follow such a great talk, so I regret that we didn't shuffle beforehand. Good. So the subtitle of that event is From Promise to Reality. And that's something I want to talk about today, how we actually get from very early research in AI, especially in pathology, to tools that can be used in practice by physicians across the globe. So I have one disclosure. Before I joined Mount Sinai, I was at Sloan Kettering, and there we founded a startup called PAGE that stands for Pathology Artificial Intelligence Guidance Engine. I will speak mostly about my work, but for the FDA, I will reference that one disclosure. Okay, so at Mount Sinai, as you all know, probably is in New York City. It's close to Central Park, and there we're building an AI initiative where we try to impact not only pathology, but all kinds of area at the medical school with AI. The Hasso-Plattner Institute that was mentioned is a collaboration with Potsdam in Germany, where we have joint work, especially on the engineering side. And everything I present today is, of course, only possible because of all the fabulous people who contributed to that. Okay, So let's start very, very high. So as you know, if you talk about AI these days, people fall either in one of these categories. So either you have the hype category, where people like Google CEO tells you AI is more profound than fire and electricity. And on the other hand, you have people who say, oh, it doesn't make sense, it will never work, it doesn't work like a human brain, it's just a black box, and so forth. What we are trying to do is firmly in the middle of that. So we try to build clinical grade AI. So tools that are so good that a clinician can use it in the clinic the same way they would use any other test. So not brittle research, but something that's very, very practical. The way we do that is, of course, machine learning, mostly deep learning these days. And to explain to you what we actually mean with that, I will describe one very specific case in pathology. Anand fabulously laid out that wide field of computational pathology where it can touch so many different areas, from the diagnostic to the prognostic and predictive side. But here we're going to discuss something very, very concrete. So very briefly for the computer scientists in the room, in pathology you take, for example, a sample from a biopsy that's then cut, put in this paraffin, in these boxes where it's embedded in paraffin. From these blocks you can then cut off these very, very thin slices of tissue. They are put on a microscope slide like that, and then they are stained with all kinds of antibodies of proteins of interest, but mostly just H&E, which are the standard pink stainings. And you end up with these very colorful collections for each patient, and a lot of them. So what you see here is the workload just in GU, that means prostate and bladder, it's low and catering for one single week. So all these folders contain dozens and dozens of slides for each patient. And that's at one of the leading cancer centers in the world. And after that, a human looks through a microscope onto that glass slide and renders the diagnosis. So pathology has not changed in 150 years. That's exactly how it was invented by Virchow in Berlin. And it's very subjective, and it depends if you have access to an expert that understands what's on that slide. And as was discussed many times before, there are countries in Africa who do not have a single pathologist. There are 9,000 hospitals in China without a pathologist. And there are many, many community clinics without pathologists. So you're completely dependent on that expert who looks at your slides. And then these glass slides are stored in vast archives, millions of these. So at Mount Sinai, we produce 1.6 million glass slides every year. And then you have to reinforce the floor and send it somewhere off. And it's really a good example of dark data. So if you could learn from the data, that would be amazing. But it's all hidden away somewhere. And it's only in recent years that these digital slide scanners actually got good enough that we can digitize at a resolution that's similar to the light microscope. I mean, Anand can certainly remember when we started in that field, the quality was just too bad. You couldn't do anything. So here's an example. And like in a good TED talk, you have a personal one. That's one of my moles. That's supposed to be negative. So these images are enormous. They are 150,000 pixels times 100,000 pixels. All your holiday snaps would fit onto a single of these slides. So it's up to 2 gigabytes, so you produce a ton of data. When you zoom in, you see the various layers of the skin, you see some vessels, and at highest resolution, you see the cell nuclei you want to detect and you want to classify to find cancer or predict, for example, outcome. So why should you care about pathology? And that's actually also reflected in how the FDA publicly thinks about that. So on the left, you have more or less screening technologies, including radiology. So if you, for example, if you find something in radiology, you have a nodule or something, you have to take a biopsy, then the tissue is put on the slide, and then a pathologist looks at it. And the pathologist then renders the diagnosis, as we saw on that picture. And everything that follows afterwards in the medical edifice, the decision how to treat, the decision what testing to be done, all clinical trials, everything depends on that subjective diagnosis of the pathologist. So how is that reflected in reality and in AI? So on this side, you have by now over 200 FDA cleared AI systems. Because with the argument, if your X-ray is not so good, you can always go back and get another one. In pathology, in 2022, just one single AI. So when we talk about hype in our space, then that happens at a completely different level than reality. If a pathologist wants to have an FDA-approved AI in 2022, they have just one choice for one application. So that shows you how actually exciting that field is and how much we can do and how we can impact it, but we are far away from too much AI in clinical practice. Okay, how do you do that now? So enter computational pathology. Most what Anand presented falls into that area that really deals with pathology from a purely quantitative computational side. My own lab works in 3 different areas. One is the diagnostic one. So here we work on tools that are useful for pathologists to help them to do what they do, but be faster and more reproducible. The second one is the prognostic predictive side. So here we try to build things pathologists or human cannot do yet. For example, predict genomic alterations from the morphology of these slides, or predict outcome based on these slides. And all of that is underpinned by a lot of computer science work in actually building compute clusters for that scale, building the compute stack for these clusters, then building software tools, viewers, analysis tools to be able to do computational pathology at very large scale. Okay, so where are we? That slide is a little bit outdated, but it didn't unfortunately change much. So we coined the term computational pathology 14 years ago, or 15 years ago. At that point, we used one tissue microarray slide. So over time, these test data sets grew, and then you had publications with 500 slides. So these days, you have 1,000 slides, maybe 2,000 slides. But the problem with these very small data sets is that they are very well curated usually. So all the bad cases are thrown out, the blurred ones, the difficult ones. So you end up with all these interesting data sets for machine learning purposes to compare methods, but that do not reflect nature and do not reflect clinical practice. And if you train systems on that, that's training like a self-driving car on an empty parking lot. It will work perfectly. Your AUC will be excellent. You think you have a great thing. It's advertised a lot. Every month you have a new article in New York Times or somewhere that says, oh, Google solved breast cancer, or this company did that, and so forth. But all these systems fail drastically when you hit reality. And the reality of pathology is very messy, very surprising, very, very diverse. The biological variability of cancer and normal tissue cannot be captured in these very small data sets. So how do we go beyond that? So from my point of view, it takes these 4 elements. The first one is new machine learning. So you need new algorithms to deal with that vast amount of data. It's significantly different than what you can take off the shelf. Just as a comparison, so this, at Mount Sinai, we produce nearly 2 petabytes every single year. So these computer vision tasks go far beyond any computer vision group actually does in practice. Second, you need enough data that the data actually represents reality for what you do. The same way you cannot train a pathologist from a book, right? If you have your most talented MD students, and they learn every pathology book by heart, they will be a poor pathologist. Because it's an empirical science. The way you learn pathology is that with your peers in consensus sign-out, you look at thousands and thousands and thousands of slides, and only then the human is able to form the pattern in our brain to recognize these different subtypes. And the same is true for an AI. If AI cannot see thousands and thousands and thousands of images, it won't work. The third is domain expertise. And that's not so much actually pathologists and oncologists because they are all eager to participate. That's mostly computer scientists. Today, if you have a PhD in Anand's group, for example, or in mine, if a student has a thesis in machine learning, before they hand it in, they're going to have an offer from Google and Facebook and Microsoft on the table. And then getting these people into medicine for a fraction of the salary is really, really, really hard, right? So one of the big issues here we have is that we have that enormous brain drain out of academia, out of the sciences into industry because we just can't compete. So that's one of the biggest hurdles that holds us back at this moment. Brain drain away from academia in the US. Last one, very, very often overlooked, high-performance computing. I don't have to say that here, which is great because all of you understand that, but usually people in our field do not. Right? They don't understand that to scale up you need more than your laptop or some cloud instance. So how did we do that? So at Sloan Kettering we started digitizing in 2015, and by now we digitized nearly 5 million slides. And that then allowed us to tie it into a health informatics system, which we built specifically for that purpose. We pulled data from the laboratory information system, from the EHR, from all kinds of consent lists and so forth, to end up with de-identified data at scale, which we then can push to the compute appliance. And based on that, we were able to build models from 12,000 slides in 2017, and the FDA-approved system these days is built on 100,000 slides. So you see that's a real phase change in that field, from academic exercise to systems that hopefully can work in clinical practice. And to do all of that, what you really need is high-performance computing. So we extended the compute cluster at MSK, and for Page, we actually built the world's largest compute cluster, which is tiny compared to Oak Ridge and so forth, but it's the world's largest compute cluster solely dedicated to pathology. So the whole infrastructure and everything is built towards these high throughput imaging tasks in pathology. It's in New Jersey. And then we have a lot of work, of course, on top of that hardware, how we can actually build the whole stack, the whole research stack, training stack, and then the MLOps stack for that specific use case. Okay, so now we have a lot of data, we have a lot of compute, we want to do some cool machine learning, but the next bottleneck is manual annotation. So usually in that field, what happens is what you see on the left, which you don't see because it's a PDF. So what the pathologist usually does is they have to manually annotate the cancer. So they paint on it where the cancer is, or they click on all the TILs and all the cells you want to detect, which is a cumbersome task. And it's also highly subjective, right? And the person who's going to annotate your data is not going to be your world-class subspecialized pathologist at Mount Sinai, but some poor fellow or graduate student who is forced to do that. And regardless how much money you throw at that, you can never ever annotate 100,000 slides or 1 million or whatnot. So you have to go beyond manual annotation. To do that, we developed a system that can directly take advantage from the pathology reports. So for example, from the report, in a simple detection case, we just pull a yes or no answer, does a slide contain cancer? And then we have that large slide, and the only thing we know if there's cancer or not. We do not know where it is, we do not know how it looks like, we do not know how big it is, nothing. But we know if there's cancer or not. And that problem can be very difficult. So here you see 2 needle biopsies, and if you zoom in, the lesion itself is tiny, right? And finding that lesion within this large slide is exactly the problem you want to solve, right? Finding the needle in the haystack. It also nicely demonstrates why a pathologist might need half an hour or even longer for a prostate cancer case, in contrast to radiologists who are very, very fast. Because finding the needle is very, very difficult and time-consuming. Okay, multiple instance learning to the rescue. So the way we approach that on a very high level is as follows. So you have a stack of slides from which you know that they are all negative, and then you have a stack of slides from which you know that they contain cancer. And what the algorithm does is it compares these slides, these 2 stacks, over and over and over again to find the difference. And the difference are not the pen markings or the normal tissue or the mimickers of cancer. The difference between these 2 stacks of slides is the cancer morphology itself. So in a little bit more detail. So you have a stack of slides here. You partition these slides in tens of thousands of small images. Then you do a forward pass through a deep convolutional neural network, and then you end up with a scoring for each of these patches for cancerous or non-cancerous. And then the hypothesis is, if it's negative, all of these should be negative. If it's positive, at least one. If there's a larger lesion, many of these are positive. Based on that, you can calculate the error or the loss, as we say in machine learning, back propagate that loss through the convolutional neural network, update the weights, and if you do that over and over and over again on your high-performance compute cluster, the system starts to learn how cancer looks like without any manual annotation. If you then get a new slide in the system, you do a forward pass through your trained CNN, you end up with potential locations of cancer, and then you use something called an aggregator that aggregates that information together. That can be done with a recurrent neural network or attention mechanisms and so forth. Good. We tested that back then on prostate cancer, skin cancer, breast cancer, mets to lymph nodes. And then if you do a little bit of mathematical gymnastics, you can take that back project it into the image and show the pathologist actually where the cancer is and how it looks like. Okay, great. All AOCs in the high 90s, right? So if you learned anything from my talk, then you should say now, Thomas, that's really nice, but I don't believe you because you told me I shouldn't believe AOCs. Right? And that's correct. Because although that's a large data set, one could argue, well, it's a MSK data set, it's very biased, it won't generalize, it's still nicely curated. So there's the proof on the scientists or on the institution or the company to prove to you that you are more than just a good AUC. So to do that, we generated an external test set of 12,700 patients out of 800 institutions out of 45 different countries. So that means the slides themselves were produced in China, in India, in Europe, in South America, and everywhere in the US, in all kinds of rural places as well. So the slides came from all these different histology labs where you had all these different variabilities of pre-analytics, how you stain them. In France, they, for example, still add saffron to the H&E stain, not only because it tastes good, but because it actually emphasizes the collagen we heard before. And what we saw, so that's the scientific publication back then, there was a little bit of a drop back then. With the 12,000 slide model, with the 100,000 slide model, it constantly generalizes across the globe. There's no drop. And also across scanners. Philips, Leica, doesn't matter. So why is that? The reason is that the AI truly focuses on the morphology, like a human does, and doesn't get thrown off by small changes of color, of lightning intensity, and so forth. And the most important part here, which was the most important part also of the Nature Medicine paper, was on this data set there was no data curation done. None at all. Any slides that was good enough for a human had to be good enough for the AI. And that means clinical grade. Good. And then you can do all kinds of introspection. You can look at various neurons. You can project it in various spaces. You see the different clusters. And you can evaluate how the model works internally, how it works on different subgroups, under different conditions, and so forth. Okay, here you see a nice animation if it wasn't a PDF. Good. So that was 3 years ago, a little bit more. So what I explained to you was a nice academic project. Right? It's a nice result, it's a nice paper, but it still does not touch a single patient, and no pathologist would ever use it. Right? And to actually go that last mile, that was the reason why we founded PAGE. And with PAGE, we started talking to the FDA very early on, already in 2018. And that started a multi-year process until we submitted a study at the beginning of last year and executed last year and submitted for approval. And that then needs a completely de novo approval because there are no comparisons before, a new device category, the whole submission, everything together was over 2,000 pages. So that's a very, very long process, and you need quality management systems and ISO standards and everything you need for a proper product. And in October last year, we were very humbled that the FDA approved the first ever AI in pathology. And the beauty of that is it also sets a standard, right? So now everybody could, for example, follow. So now you don't need a de novo application, you can just have a 510K. But that was over a year ago, and people thought, okay, now there are going to be 50, 100 new applications, but there have been 0. And the reason there have been 0 is because the bar in pathology is so high. In that study, we had data from 217 different institutions. It was enriched for difficult cases. And the reality is most things out there, which are often very overhyped, cannot stand the test of reality. And it was very nice to see that actually the FDA director even said, so that technology ultimately can save lives. And if you're a computer scientist like me, that's something you hear very rare, very, very rarely, that you can actually save lives by writing code, which is very nice. So the study for the FDA has to look differently actually than everything I showed you before. That was a retrospective analysis I showed you. So here we had 16 pathologists diagnosing cases, on-site, off-site, specialist, non-specialist. They were reading remotely or reading on-site. The data was from 22 different states, 5 different countries, 217 institutions, multiple ethnicities, and 50% were actually enriched with extremely difficult cases. So you don't have just easy cases in there. And difficult means really difficult. So here, for example, is a case where all the pathologists, when they read it without the AI, all the pathologists agreed these are is a benign case, so no cancer. And after the AI actually pointed out the cancer here at the border, all the pathologists agreed that there is indeed cancer, and it's actually quite high-grade cancer, so it will influence the treatment of that patient. And overall, the error rate of pathologists before and after with the use of the AI was reduced by 70%. So enormous, significant improvement of sensitivity for all pathologists, for a specialized one, for non-specialized one, regardless if they were reading remotely or if they were reading on site. So in the past, in radiology, for example, high sensitivity is often bought at the cost of low specificity. So you have all these false alarms which make then your algorithm useless. And that can be very difficult here. So here's another example with a seminal vesicle. On that side, you see it very, very well. And on the other side, you actually see it very poorly, and it looks a little bit like cancer. And indeed, 2/3 of the pathologists wrongly classified that as cancer. And after the AI told them it's not, they actually reconsidered or deferred the case, because in reality, they can also say, I want a different level, I want to stain it, I want to show it to your colleagues, so you can defer it, so it's not just binary. And overall, even the sensitivity increased slightly, so a total reduction of 24% in false positives. So you have now an AI that helps pathologists to not only be more sensitive, but even more specific. And overall, the unnecessary deferrals were reduced by 24%, and the necessary one, where cancer would have been missed, were increased by 59%. Okay, so today, that system is now used in clinics all over the world, not only at MSK, but also in Oxford, in Brazil, for example, in one of the largest cancer chains we talked about today, at other places in the US and in Europe. So that's the first example of a really large-scale AI, and the first FDA-approved one that is used for patients daily in practice. So what that should show you is that there's really hope to go from the promise into reality, and that AI is able to do that and really improve patients' lives at the end of the day in a quantitative manner. In the meantime, the results have been reproduced by Yale, in Cornell, in Brasilia, and everywhere. And very important for all these places, the AI works off the shelf. So you don't have to calibrate for your local data set at all, right? So it works everywhere. Good. For the sake of time, I think I'm going to skip the next part. So the next part of pathology are these novel biomarkers, computational biomarkers, but Anand gave fabulous examples of that. We also do that to predict, for example, response to immune checkpoint inhibitors in lung cancer, or predict EGFR and so forth. And at Mount Sinai, that's something I wanted to say, we actually founded a department for AI and human health, which is a computer science department for computer scientists who spend their life in healthcare, so that there is a central place where the computational faculty can come together and you're not tucked away somewhere else. Well, obviously, I have to end. Yeah? And you're all invited, of course, to visit. We have open positions from postdoc to assistant associate and full professors at that institution. And what I showed you today was just pathology. Right? What we want to build at Mount Sinai is really a fabric of these AI services, where we do what I just showed you in pathology, but do similar things in radiology, cardiology, pulmonology, and so forth. And you can envision here a future where you have all these very practical, clinical grade AIs that really give you a much more holistic picture about the patient, and also inform the institution how to better treat their patients. And at Mount Sinai, we have a very diverse population, which is absolutely key to make sure that your AI is not only safe and effective, but also equitable. Okay, so thank you very much.
Hi. Great talk and great achievement. I'm interested, curious about the question. So I know a lot of companies are working on AI for pathology. So what is the uniqueness in the page that beat other companies? Is this technology or algorithm or the sample from the Memorial Sloan Kettering, or what's the uniqueness?
So it's really the four things I described, right? So first of all, it is machine learning algorithms that are very unique. Second of all, you have to invest in data production, right? And data sharing also means, for example, first investing into data, which is hugely, hugely expensive. But then most importantly, you actually have to have a HPC cluster, and you have your cluster under control. So to build a system instead of a few hundred slides on 100,000 slides and do that reliably across tumor types needs so much engineering knowledge that no other company or institute does that today. So there's nobody else who builds currently globally models at that scale. And yeah, that needs HPC.
Thank you. That was a great talk. I have a question about how, have you looked at how this impacts clinical workflow and the time that clinicians spend on images? Because there was some articles in Radiology that they were showing when the AI flagged an image as having something they need to look at, they ended up spending more time searching that image, and it actually increased their workflow. So have you looked at that at all? And I'd love to hear your thoughts on that.
Yes, so very, very important, because that's what actually kills it in practice, right, are these things. So at the European Pathology Conference just 2 weeks ago, unfortunately I couldn't go, there was an independent study presented from Portugal, from Porto, from Dr. Katharina Eloy. They used Page completely, our AI completely independently, and they saw a reduction in time of, I think, 25%, but more importantly, a reduction of IHC staining of nearly 50%. So pathologists are very confident when they actually see the cancer and don't order stains. So that's also a reduction in cost in healthcare systems where that makes sense without any loss of accuracy. So yes, it does help, and it's key to evaluate it. In addition, we are part of a very long NHS study over 2 years that analyzes in detail how these algorithms impact workflow.
Zhen Xiao from Leidos Health Group. In addition to Leidos Biomedical Research, we support other NIH institutes and also Army and Defense health agencies on their pathology efforts. So I realized, first I want to congratulate on the Page platform FDA approval. On one of the slides you mentioned you still observe some slight variation when you compare the on-site versus remote options. So I want to see if you can elaborate on what are the factors contributing to the remote versus the on-site, because in the military setting it's just as diverse. Yeah, in Europe or in Asia, they have different sites. How we can synchronize and minimize the difference.
Yeah, so the differences are actually quite minimal between remote and on-site. And I do not think that they are in any way significant. Independent of AI, there have been many studies, also one by us, at the beginning of the pandemic that actually compared on-site versus remote reading, which actually led to this emergency use authorization by the FDA to allow remote viewing in pathology, as it is already possible in radiology. From my personal point of view, nothing speaks against remote viewing at all, and that should become the standard, especially in a scenario where we don't have enough pathologists. So in America, in the US, the number of cases go up, the difficulty of the cases go up, but the number of pathologists go down. It's very important to understand that just to keep the standard of care of today, we will need AI to support pathologists. So, and if pathology is the last discipline that only can be done on site, that would make no sense and just hurt patient care.
Yeah, so given that this kind of variation will exist, no matter what we do, the remote versus on-site, there will be some variation. What are the suggestions or future improvement you are going to study further on?
Yeah, so again, I don't think, so let's look just at the bright bars, which are pathologists without. So the 2% difference, we would have to run the statistics. I don't think that's significant. So I would not worry about that. But of course, you have to train your pathologist. You should not do it on your iPad. You should have a decent setup. at home. So things like that.
Mm-hmm.
But I don't see a reason not to do that.
And another question I have is on the timing. As you know, there are some very older slides we call archive slides.
Mm-hmm.
So how are you going to deal with that when you digitize those archive slides? Or you're going to focus on the newer, more fresh slides and what the factors you're going to consider?
Yeah, so we actually set up archive scanning operation in the glass archives, where we had a dozen scanners to actually still have to scan old slides. And that's the beauty of pathology. You can actually go back in time and scan a slide that's 10-year old, right? 10 years old. In radiology, you can have the patient come back if you have a new scanner, right? So that's very good. And the reason to do so is that for these patients, you then have outcome information, right? And then you can train models, as I didn't go into detail, against survival, against outcome, against recurrence. But in prostate, it's even worse than that, right? Because you would like to have follow-up between 20 and 30 years. So we're working, for example, with some European countries who actually followed up the whole male population in some areas over 30 years, so that you can, at that point, hopefully learn predictors that are better than the ones we have today and maybe end up with a better Gleason grade, for example.
Thank you. Great work.
Thank you.
Thank you so much.
Thank you.
We're going to take a short break now. I'm going to try and get us back on schedule. So if we can be back by 10:20, 10:25 at the latest, we'll get started. We have 2 more talks before we have the panel session. Thank you.